Hello, everyone. For those of you who don't know me, I'm Venkata. I was a PhD student with Siv and Mohammed Kohandal way back in 2009. Worked on radiation-induced secondary cancers, and there was a great sense of pride in terms of working with Siv and Mohammed Kohandal back then, and in the specifically in biomedicine group. And it's been a great privilege, Siv, that I'm sharing your legacy and the celebration here with you. You've been a great support to all of your students and a great mentor. Thank you very much. So today I'm going to talk about some of the research that we have been carrying out in our lab, specifically on moving towards genomically driven interventions in precision radiation oncology. So over the years, cancer progression has been recognized as an evolving crosstalk that happens between the tumor epithelial cells and the stromal cells. If you look at the normal epithelium here, there is two different compartments, the epithelium compartment and the stromal compartment, which is very nicely delineated by a basement membrane. And the stroma here consists of fibroblasts, myofibroblasts, collagen, ECM, endothelial cells, immune cells, so on and so forth. As it moves from the normal epithelium state to the pre-malignant state where the cells have the potential to become cancerous, the stroma here gets activated. While the basement membrane is still intact, there is a disruption in the proliferation ability of the epithelial cells. When it moves to the final or the carcinoma state, as you see here, the basement membrane is degraded, and there is a heavy crosstalk that happens between the tumor epithelial cells and the stromal cells, leading to different types of signaling interactions like autocrine interactions, paracrine interactions, so on and so forth, resulting in invasion, metastasis, recurrence, and even resistance to therapies. So in the clinical management of cancer, there are 5 therapeutic interventions starting from surgery, chemotherapy, radiation therapy, targeted therapy such as EGFR inhibitors, KRAS inhibitors, so on and so forth. And the latest addition to this list being immunotherapy, which is usually given for aggressive cancers like triple negative breast cancer, high-grade serous ovarian cancer, melanoma, non-small cell lung cancer, so on and so forth. So as we are in the era of big data, it comes in various heterogeneous and diverse forms. So starting from electronic health records, and we have pathological slides where the biopsy is taken, you do an IHC to it, and you digitalize the pathological slide, and you also have other medical imaging modalities such as CT, MRI, and PET, and genomic data such as gene expression like RNA sequencing, whole exome sequencing, whole genome sequencing. And the latest addition to this list is are the spatial transcriptomics data, where we can get a lot of insights into the cell-to-cell interactions and so on and so forth. And you also have the drug response or radiation therapy response or immunotherapy response. And also recently, because of this AI and machine learning era, we have the wearable technologies wherein we can monitor a patient's health over a period of time. And these are all the big data sets that are highly multidimensional and highly heterogeneous and diverse and come in various scales. So the question is, how can we leverage all these, integrate all these different data sets, either applying mathematical approaches, bioinformatics approaches, or even AI-based approaches, and select the optimal therapy to the patient. So the objective here of precision oncology is to identify the right therapy to the right patient at the right time. So here the focus of my presentation is on radiation therapy. So as we all know, more than 50% of the patients receive radiation during their course of their disease, either alone or in combination with chemotherapy. It could be sequential or it could be a concomitant therapy where radiation and chemo are given at the same time. So the aim of radiation therapy is to remove all the tumor clonogens from the system by maximizing the tumor control probability while minimizing the normal tissue toxicity. And in the clinical practice, this is termed as one-size-fits-all strategy, wherein the clinicians prescribe the dosing or the fractionation regimen based on the clinical variables such as the age of the patient, the gender of the patient, the smoking status, lymph node status, so on and so forth, and the dosimetry variables. Such as what kind of energy beam is coming in from the linear accelerator, how many beams are coming in, what is the angle of each beam, so on and so forth. So as we are heading into the precision radiation oncology approach, it's composed of 3 major components. The first is a technical precision, wherein we are trying to improve the treatment accuracy and of the planning and also the dose delivery. It comes into the medical physics aspect where I'm not getting into much, but something very exciting for me is the biological precision, wherein we are looking at the biology or the molecular features of the tumors using different types of omics data, and understanding more of the behavior of the tumors. And also, can we combine radiation therapy with other molecular agents so that we can increase the efficacy of radiotherapy? And also mitigation of toxicities. And we have a lot of side effects or toxicities that arise due to radiation. Now, the question is, can we come up with biomathematical models to investigate the toxicities using the dosimetry data that comes out of this treatment planning system? And this is a real image of a pediatric Hodgkin's lymphoma patient who is being treated with IMRT, intensity modulated radiation therapy. And the tumor is basically located on the lymph nodes, which is under the armpit and near the thyroid. And the three organs of risk here, or the healthy organs that are getting irradiated, are the breast tissue, lung tissue, and the thyroid tissue. So we are trying to minimize the toxicity for these healthy tissues as well. So in the context of precision radiation oncology, we have seen this plot many a times, wherein on the x-axis you have the radiation dose, the units of radiation is in gray. On the y-axis you have the probability in terms of percentage, and you are trying to maximize the area between the two curves here, the tumor control probability and the normal tissue damage probability. Traditionally, this is a function of the clinical variables and the dosimetry variables. But as we are getting into the era of big data, wherein you want to understand the molecular features of the tumors, so you want to add the molecular profiling. It could be the omics or even medical imaging data, and the biomathematical models if you are interested in minimizing the toxicity induced by radiation or a combination of radiation and chemotherapy. So this is an example of biologically driven radiation therapy. There's a database of Danish head and neck cancer patients. On the x-axis, you have time after treatment in terms of months. On the y-axis, you have the survival. So back in 1985, the radiation regimen was given in just 5 fractions, wherein the percentage of survival was only 27%. And when you are exploiting the biology of the tumors by integrating the radiation with nimerazole, which is an hypoxic cell modification factor, the survival increased from 27% to 44%. And when you change the type of the fractionation regimen, it went to 62%. Now, when you included cisplatin, which is one of the toxic agent used in the clinic with radiation therapy, the survival increased to 83%. So when you kind of understand the molecular aspects of the tumors, you can kind of increase the survival rate of the patients, right, starting from 27%, where the fractionation regimen is just radiation. It's just a single modality. And when you're integrating other modalities, you can kind of increase the survival rate to almost close to more than 80%. And also, we are looking at different types of drug and radiation therapy combinations. In the clinic right now, there are a lot of toxic compounds that are being administered. For example, cisplatin or 5-FU, doxorubicin, which are highly toxic. Now, the question is, can we come up with alternative, less toxic compounds that can increase the efficacy of radiation therapy when given at the same time with radiation? So the question is, can we identify or can we exploit some of the biological characteristics of these tumors and increase the therapeutic efficacy? So as radiation traverses through the tissue, there are a lot of biological events that occur. And the outcome of radiation therapy is a function of several variables. For example, the hypoxic, the hypoxia in the tumor. Does the tumor have chronic hypoxia or acute hypoxia? And you also look at the intrinsic radiation sensitivity of the tumor. You can look at the immune microenvironment, so on and so forth. So the question is, can we come up with alternative, less toxic compounds that can increase the efficacy of radiotherapy when administered with it? So some of the questions that we are trying to address is we are looking at developing radiation response biomarkers. And one of the first question is, what is the indicator of radiation response that should be used as an outcome variable in order to build any kind of model? And some of them, we are also looking at developing some of the models for DNA repair. And can we come up with putative radiation sensitizing and radiation protective compounds in combination with radiation therapy? And we are also looking at developing an assay for clinical translation, and also looking at other questions like, is the biological response or the molecular response induced by photons and particle therapies, is it the same, and how different it is? And we are also developing computational toolboxes for biologists and clinicians as well. So now the question is, we agree that there is the requirement for biomarkers. So what exactly is a biomarker of radiation response? If you're looking at pharmacogenomics or in terms of drugs and compounds, you know that there are hundreds of drugs, and we want to identify the right drug to the right patient. But radiation therapy here is just a single entity. What exactly do we mean by a biomarker of radiation response here? So there are a lot of patients or a group of patients wherein you want to de-escalate the dose. For example, the tumors are radiation sensitive, because of no hypoxic regions, or there are less number of cancer stem cells. So you want to decrease the radiation dose and decrease the side effects of radiation on these patients. Next, we want to identify a group of patients for whom the tumors are radiation resistant, right? So you want to increase the dose for these patients so that you want to increase their overall survival. And finally, you want to also identify a group of patients for whom radiation and chemo can be administered together, because radiation and chemo together is very toxic. So you don't want to administer radiation and chemo for all the patients. So you want to identify only for a set of patients. Now, the next question is, what kind of models do we use? So first one is the patient model systems, wherein there is a lack of treatment response data and the molecular data available from these models. And if at all they're available in small data sets. And the second model system is the mouse models, and wherein they do have they do have the ability to recapitulate the tumor response. However, they're very, very expensive to kind of build like hundreds of mouse models. Finally, we have cell lines 2D or 3D. These are available in large quantities. They're less expensive to kind of generate this in the lab. They're available in, we do have the dose response data as well as the omics data. But one of the problems is they do not encompass the real features. But this is the simplest model that we have. The question is, can we kind of build a model that can be used to predict the radiation response in the simpler model before even extrapolating it to very complex models? And these are the two largest data sets that we have in the literature in terms of radiation screening. And this is the Cleveland data set that was published in 2017, spanning across 511 cell lines and 25 tissues. And this is an NCI 60 panel, which was done back in 2008, spanning across 60 cell lines and 9 tissues, and for which we have the corresponding dose response data and the molecular data. Now, the question is, can we identify what are all the molecular features that are associated with this dose response and build appropriately the biomarkers? So in order to do that, we kind of nicely curated and built a very cool platform called as RadioGX, wherein we took all these big data sets like RNA-seq, microarray, DNA-seq, so on and so forth, pre-processed them, did quality control, annotated them, normalized the molecular profiles, and we created some kind of an expression set along with the corresponding dose response data, wherein it has like tons of utilities. You can download it from GitHub or from CRAN, a bioconductor, and utilize it for various functions. And these are all some of the utilities of this particular package, starting from concordance of data sets to biomarker discovery, to modeling effect of hypoxia on radiation response, to modeling fractionation regimen, and also looking at radiation response and drug response using pharmacogenomics data and radiation genomics data. And we are also looking at building a nice web-based tool. This is being done by a high school student, incidentally, this summer, and it will go live hopefully in a month or two. This is basically the purpose of this tool is to make the clinicians or non-computational people utilize or leverage radiation genomics data sets. And this is the holy grail of radiation oncology, where I think most of you would have known, called as a radiobiological model. On the x-axis, you have the absorbed dose, the units of radiation is in gray. On the y-axis, you have survival given in terms of percentage. Here you have low LET radiation, which is a photon radiation. The surviving fraction of cells for a given radiation dose D is this linear quadratic function minus alpha D minus beta D square. For the high LET radiation, such as ion therapies or particle therapies, such as proton and alpha, you have exponential minus alpha D, where beta value equal to 0, where alpha and beta are called as radiobiological parameters here. So when we use this particular model to fit all the 511 cell lines, is an example of the fit. One is a radiation resistant cell line, another one is a radiation sensitive cell line, where for radiation resistant cell line, you have the beta value equal to 0, and alpha and beta are not equal to 0 for radiation sensitive cell line. And the first question that we tried to answer is, what is the best radiation response indicator? For example, if you're looking at pharmacogenomics field, for a given drug dose response curve, you have IC50, EC50, AUC, 1 minus AUC, so on and so forth, which can be drug response indicators. In radiation therapy, what exactly is the indicator? So for that, traditionally, people use SF2, which is a surviving fraction of cells at 2 gray of radiation. And this is a point estimate. And intuitively, as mathematicians, we believe that AUC under the fitted radiobiological model could give a better indicator of radiation response. But when we looked at the correlation between SF2 and AUC under the fitted radiobiological model, boom, we get the correlation of 0.92, and it's statistically significant. Now, when we break it down into tertiles based on sensitive cell lines, intermediate cell lines, and resistant cell lines, the correlation decreases, say, from 0.8 to close to 0.45. And one of the reasons here is the value of SF2 doesn't change much as we move from sensitive cell lines to resistant cell lines, but the value of AUC is changing drastically, due to which we see a poor correlation. But appearances can be deceptive. So what about at the molecular level? So whatever we are seeing is only at the cellular scale in terms of counting the number of cells, right? So what about at the molecular level? Does it lead to the same conclusion or a different conclusion? So for this, we looked at a simple bioinformatics approach, in terms of pathway analysis. Pathways is nothing but a bunch of genes that drive a biological signal, for example, a proliferation or immune, so on and so forth. So we have the dose response data here, the SF2 value, surviving fraction at 2 gray, as well as the area under the curve of the fitted radiobiological model. And we also have the corresponding omics data here, which is the gene expression. And we compute the correlation between every gene with the AUC or the SF2 to get a gene level statistic. And we run a GSCA algorithm here. For example, cell cycle pathway is positively enriched here, and metabolism pathway is not, there is no enrichment here for this particular pathway. And we took almost close to 600 pathways to run this kind of an analysis. And what we found is something very interesting. So on the x-axis here, we have AUC of the fitted radiobiological model with minus log 10 FDR. FDR is a false discovery rate corrected for false positives. On the y-axis, we have SF2 minus log 10 FDR. And we notice that the number of pathways that are enriched specifically with SF2 are just 3 in number compared to AUC, which are 42. While there are a lot of pathways that are common between SF2 and AUC. And moreover, we found cell cycle pathways, which is one of the most important biological phenomena with radiation therapy, to be enriched with AUC compared to SF2. Also, we found NERV2 pathway, which is related to radiation resistance, to be enriched with AUC compared to SF2. So this kind of conveys in an in silico way that AUC captures more biological processes compared to SF2 of radiation response. So the next question is, are there any biological similarities or differences between across tissues for radiation response? And in order to test this hypothesis, we looked at all the tissues for which the sample size is at least n equal to 15. And on the x-axis here, you have all the tissues where the sample size is n equal to 15. On the y-axis, we grouped all the biological pathways based on their functions. And we ran the same pathway analysis, and we found a total of 281 pathways that were upregulated or downregulated. And more interestingly, we found radiation sensitivity pathways to be upregulated or enriched more compared to radiation resistance pathways. This kind of tells us that radiation response may be tissue specific and not tissue agnostic. So the next question is, are there any signatures out there that are being used in the clinic? The answer is no. So we kind of compiled a database of radiation response signatures in oxic conditions and hypoxic conditions of close to 40-45. We are still updating this. So there are 2 methods that were used in the literature. One is the data-driven method and hypothesis-driven method. And we found that there are no independent external validation that was done on any of these signatures that were compiled in this paper. And different statistical approaches were done, different platforms, and resulting in non-reproducibility of these signatures. And signature development was also underpowered due to the lack of sample size. And incidentally, all the signatures have used the 2008 data set, but no signature or no authors have actually validated the signature on the 2017 dataset, which is comprising of 511 cell lines. So this kind of suggests that there is a need to kind of build a robust radiation sensitivity signature that is agnostic to technological platforms. And this is the most often widely spoken referred signature in the literature. It came from Cleveland Clinic, called as GUARD. There are a lot of concerns and issues that were raised on this particular signature. And one of the most important things is external validation. So this particular signature, which is heavily used and it's also in clinical trials right now, it fails in terms of validating the model in cell lines with the recent 2017 data. So the true values and the predicted values correlation is close to 0.65 to 0.7. So there is a lot of concern in terms of utilizing this particular signature in the clinic or translating it to the clinic. So based on this premise, we kind of, I'm almost there. Another 2 minutes. So based on this, so we kind of looked at a hypothesis that whether the SF2 or AUC, is it, which indicator is better, and in terms of the pathway databases. So whatever we have done, shown till now, we utilize only one single pathway database. The question is it pathways dependent or is it pathway independent in terms of the radiation response indicator? And we also developed a simple multivariate signature based on the best response indicator. And we use again the pathway analysis here. And we found that irrespective of the pathway databases, we still found AUC to be a better indicator of radiation response compared to SF2. And one more very interesting thing is, in every pathway, there is something called as the leading edge genes, which are a set of genes that drive a biological signal. And we found that the genes that are driving AUC and SF2 are completely different in terms of the biological signals. And for the analysis pipeline, in terms of building the signature, we have very nice data sets. One is, the Cleveland data set, which was published in 2017, which has 500 cell lines. And for validation, we have used the NCI-60 panel. We used the outcome variable to be the AUC of the fitted radiobiological model. And we obtained on the discovery set, close to like 0.63. And on the validation set, we got close to 0.6. And some of the ongoing work right now, very exciting, is we already have this nice tool or a package called as RadioGX, from which we are building the signature. And on the other side, we have the pharmacogenomics data set, wherein we can obtain for any given signature the corresponding radiation sensitizing agents and radiation protective agents, from which we can kind of do some kind of an in vitro and in vivo validation, response, and toxicity. To summarize the findings, we built a very nice platform called as RadioGX for integrative genomics analysis. We also looked at building a genomic signature database to accelerate any kind of preclinical biomarker discoveries. We demonstrated that AUC captures more molecular processes compared to SF2, at least in silico, and it is pathway agnostic. And we also developed a multivariate molecular signature using AUC as a response variable. So to conclude, the analysis of high throughput data is very, very challenging because of the noise that comes with it in terms of building any kind of predictors. So we need more data sets to kind of validate the models. Finally, we need to have an interpretable machine learning models to translate to the clinic. With this, I would like to thank my amazing lab members, along with my collaborators and the funding agencies. Thank you so much. If you have any questions, I'll be happy.
Exactly. So with this, the session